Good day, doctors. Today we will talk about risk factors for tooth decay, enamel caries, cariogenic situations in the oral cavity. Lecturer Markusheva Natalia Vячеславовна, Department of Pediatric Dentistry and Orthodontics, Bashkir State Medical University. Purpose: to study the factors that determine caries resistance of enamel. Methods for assessing caries resistance of enamel. General and local caries risk factors. Mechanism and action. Ways to eliminate cariogenic situation. Questions of the lecture. Structure and properties of enamel. Risk factors for tooth decay. Modern ideas about the mechanism of de- and remineralization of enamel. Methods for assessing caries enamel resistance. Cariogenic situation in the oral cavity. General and local risk factors in the occurrence of caries and the mechanism of their action. Assessments of the cariogenic situation in the oral cavity. Ways to eliminate cariogenic situation. To understand what a cariogenic situation is, it is necessary to recall the structure of enamel, its properties, and to find out the risk factors for caries. Enamel is one of the strongest and most durable biological materials. Enamel composition. Primary, it is 96% of inorganic material, forming enamel prisms and enamel plates. A half of 1% the organic materials, forming lamels, enamel tufts, and enamel spindles, and 3.5% is water. Thus, the enamel prisms are collected in bundles, and between them there is an interprismal space. On the vertical cut of the enamel, two types of lines can be distinguished. The Gunther-Schroeder lines. They are almost always direct, perpendicular to the enamel surface. It is an optional phenomenon due to change in the direction of the enamel prisms. And Ritzius lines. These are growth lines that are directed obliquely from the dentin enamel junction to the enamel surface. Enamel prisms are the main elements of enamel. The total number of prisms in the enamel ranged from 5 to 12 million, depending on the size of the tooth. The enamel prisms are separated from each other by an interprismatic substance. Each prism has a diameter of 3 to 5 nanometers. The thickness of each prism is from 4 to 6 microns. The prisms can be rectangular, oval, or keyhole shaped. It depends on the cut angle. The prisms have a complex orientation. Through a whole layer of enamel, they are directed perpendicular to the dentin surface. Each prism contains highly packed hydroxyapatite crystals. Thus, the structure of the enamel has several orders. From smallest to largest are: first order, hydroxyapatite crystal cell. Second, hydroxyapatite crystal. Third, enamel prisms. Fourth, bundles of enamel prisms, lamel. Crystals of apatite like Olgin are submicroscopic enamel formation. The structural unit of a crystal is a unit cell, which is unique for each types of crystals. Mineral components of enamel are present in the form of compounds with a crystalline structure. The structural macroscopic unit of the prism is hexagonal crystals. It can be hydroxyapatite, carbonapatite, chlorapatite, fluorapatite, etc. With age, the mineralization of the enamel increases, which leads to the accumulation of fluorapatites in its thickness. The main minerals components of enamel. Calcium is about from 33 to 39%. Phosphates from 16 to 18%. The calcium-phosphor ratio is 1.67. This is molar mass. Corresponds to the ideal ratio, but calcium ion can be replaced by similar chemical elements, for example, barium, chrome, magnesium, etc. At the same time, the ratio of calcium to phosphor decreases in that case. It decreases to 1.33%. The properties of the apatites change and the enamel's resistance to unfavorable condition decreases. An inverse relationship was established between the content of calcium and phosphorus in the enamel and the degree of caries damage. The surface of the tooth, where the enamel contains more calcium and phosphorus, is much less likely to be affected by caries than the surface of the tooth, the enamel of which contains less of the substance. Trace elements or mineral components of enamel, depending on their location in the enamel, are divided into three groups. The first group includes minerals which are most in the surface layer of the enamel. These include fluorum, zincum, plumbum, stibium, ferrum. The second group includes minerals which are most in the deep layer of enamel. These include natrium, magnesium, carbonic acid, salts. And the third group consists of minerals evenly distributed throughout the enamel. These include strontium, cuprum, aluminium. Different compounds will form different crystals of apatite. For example, hydroxyapatite is the tooth enamel. In the tooth enamel takes 75%. Most abundant in mineralized tissues. Carbonapatite takes about 19%. Mild, easily soluble in weak acids, all easily destroyed. Chlorapatite takes about 4.4%. It's soft. Stronzoidal apatite takes about 0.9%. not widespread in mineral tissues and common in enamel nature. Depending on the degree of mineralization and the thickness of the enamel, there are risk zones on the tooth. These are poorly resistant areas of tooth enamel. For example, the enamel in the fissure area, the neck of the tooth, is hypomineralized. The calcium content is reduced in it. Areas of teeth resistant to caries, cusps of molars, premolars, cutting edge of incisors, are characterized by a high degree of mineralization. They show an increased content of calcium. The composition of the enamel varies with the age of the patient. For example, there is the concept of maturation of tooth enamel. Maturation means an increase in the content of calcium, phosphorus, fluoride, and other components, and an improvement in the structure of the tooth enamel. The reasons for studying this issue was the numerous observation of changes in teeth and especially enamel after the eruption. For example, it was found that the teeth of the elderly are more resistant to the action of demineralizing solutions. This can be explained by the fact that the mineral composition and structure of enamel and dentin change with age. Previously, it was believed that the change in chemical composition depends on the flow of substance through the pulp. However, according to the latest data, the change in the mineral composition of the enamel is due to the entry of various substances in it from salvia. It has now been established that the accumulation of calcium and phosphorus occurs in the enamel after the eruption of a tooth, most actively in the first year after the eruption of a tooth, when calcium and phosphorus are adsorbed in all layers of various zones of the enamel. In the future, the accumulation of phosphorus and after 3 years of age, calcium quickly slows down. Fluoride plays an important role in enamel maturation, the amount of which gradually increases after the eruption of the tooth. The additional introduction of fluorine reduces the solubility for the enamel and increases its hardness. Other microelements that affect the maturation of enamel are vanadium, molybdenum, strontium. The mechanism of enamel maturation is not well understood. It is believed that changes occur in the crystal structure, the volume of microspaces in the enamel decreases, which leads to an increase in its density. Also, resistance to dental caries will depend on the properties of the enamel. Among them are permeability. This is the ability to pass water and substances dissolved in it. Resistance to mechanical and chemical factors. This is the ability to resist the action of acids. Trophic function. This is a metabolic process due to calcium and phosphorus, trace elements. The permeability of the enamels depends on the group belonging of the tooth. The permeability is higher in molars, than in incisors and canines. The level of permeability of the enamel increases at pH 4 to 5. Treatment of the enamel with acids application. Chymotrypsin. The level of permeability is reduced. High concentration of alkaline, phosphatates and fluorides. The process of replenishing the deficiency of trace elements will depend on the properties of the enamel and the content of trace elements. Continuous process of remineralization and demineralization in tooth enamel normally compensate each other. Remineralization is a partial restoration of damaged enamel. Demineralization is dissolution of enamel under influence organic acids, accompanied by a change in the shape, size, and orientation of hydroxyapatite crystals. Don't confuse these concepts with the process of mineralization, primary, secondary, and tertiary. Mineralization is repainting of enamel during the laying period, tooth development, during and after teething, eruption. Formation of an organic matrix, enamel prisms, and their primary identification. This is a primary mineralization. Secondary mineralization is maturation. We discussed it earlier. And final definition of enamel, tertiary mineralization of enamel carried out after erupting, after teething. Demineralization of enamel takes place in 3 stages. First stage is white spot measuring from 1 to 3 millimeters. The next one is advanced stage. Slow demineralization is characterized by uniformity of enamel changes. When probing, the surface is smooth but dense. The intensity of staining with methylene blue is from 4 to 5 points on a 10-point scale of shades. Rapid demineralization is photo of enamel lose clear boundaries. The surface is rude, dull, the probe gets stuck in the areas of demineralization. The enamel is scraped off by an excavator. The intensity of staining is about 6 points on a 10-point scale of shades. And the third is the stage of the defect, characteristic of fast-flowing demineralization. Sources of enamel remineralization are salvia and remineralizing drugs, calcium, phosphorus, fluoride, strontium, zinc, etc. A little about anti-cariogenic factors and dental caries resistance. The first, the susceptibility to caries depends on the type of mineralization of the hard tissue of the tooth. Yellow enamel is more caries resistant. With age, the crystalline needle is compacted and the caries resistance of the teeth increases. Second, caries resistance is promoted by the replacement of hydroxyapatite with fluorapatite. They are stronger, more acid resistance and less soluble. Fluoride is an anti-cariogenic factor. 3. Caries resistance of the surface layer of enamel is explained by the increased content of microelements in it: strontium, zinc, ferrum, vanadium, etc. For example, selenium, silicon, cadmium, magnesium are cariogenic. 4th, vitamins D, C, A, B, etc. contribute to caries resistance of teeth. And 5. Mixed salve has anti-cariogenic properties. For example, it depends on composition and properties. There are several ways to determine how likely a patient is to have caries. These are tests of enamel resistance to dental caries and clinical assessment of the rate of enamel remineralization, determining the resistance of teeth to caries. So, enamel resistance test, third test. Indication for use: to assess the level of resistance to caries and to assess the caries preventive effectiveness of remineralizing agents. There are 6 steps to do these tests. The first one is: on the cleaned and dried vestibular surface of the upper central incisor, a drop of 1H-hydrochloric acid solution for 1.5 mm in diameter is applied in the center. Second, after 5 seconds, the acid is washed off with water. Then the tooth is dried, and drop of 1% aqueous solution of methylene blue is applied to the itching site. Next, the itched area is colored in different shades of blue, and color intensity is assessed according to a standard 10-point color scale. On the slide you can see the staining of the central incisor with methylene blue of varying intensity. The intensity will depend on the degree of enamel demineralization. The more demineralization, the bluer the tint of the stained area. More demineralization is more blue. Clinical case: a 2% methylene blue solution is applied to the etched enamel on the second incisor of the patient. Then you wash down methylene with water, and you see staining of the etched enamel area after dye removal. Then you assess the color intensity using a 10-point scale, and you see that the staining area of tooth is correspond to 8 from scale. Then you can take enamel state evaluation table, and we'll see that 8 and more is extremely low. Tooth decay resistance, extremely low. To eliminate the resistance of tooth enamel from caries, you can take the table with 2 columns and 4 lines. First column is color strips, and the second color is evaluation of tooth decay resistance. And you see that it can be high, medium, low, and extremely low. The next test is clinical assessment of enamel remineralization rate. On Russian it sounds like KOSRE test. To do this test, the tooth is cleaned of plaque, dried with air, and drop of hydrochloric acid buffer pH from 0.3–0.6 and applied to the tooth. After a minute, the demineralization solution is removed from the etched enamel area for 1 minute. A tampon with a 2% solution of methylene blue is applied to the tooth. The stained area is evaluated on a typical 10-point scale. After 1 day, restaining is carried out. If the area is pigmented, the procedure is repeated again, the day by day. If the painting area is disappear from 1 to 3 days, this means that this is a high salivating ability of salivary. If more than 4 days, is low salivating ability of salivary. As I said, the properties of salivary will affect the remineralization process. The first one is salivation rate. How to determine the rate of salivation? Saliva is collected for 5 to 15 minutes in graduated centrifuge tubes. The salivation rate is determined by the formula V divided on T, where V is the volume of salvia in vitro and T salvia collection time. There are 3 types of salivation. Secretion is about from 0.0 to 0.3 milliliter in minute. It's slow. Normal secretion is from 0.3 to 0.6. It's medium secretion. And hypersecretion, it's more than 0.6. When salivation rate is below that 0.3 milliliter on minute, a cariogenic situation is carried in the oral cavity. The next test is CRT test, color reaction time. The principle is based on the ability to dissolve tooth enamel and change to the color of indicator paper. For this, a certain amount of 1 molar hydrochloric acid is used, applied to the enamel surface using indicator paper with a diameter of 2 mm. The CRT test is carried out as follows. The labial surface of the test tooth is cleaned and dried. Then a circle of indicator paper moistened with hydrochloric acid is applied to the surface of the tooth. The time that elapses from the moment the acid is applied until the color of the indicator change from light green to purple is set using a stopwatch. This incision is considered a relevating measure for determining the acid resistance of enamel. Calcium ions in the enamel impregnate the disc and discolor. If this happens quickly, then the tooth is prone to caries. The longer it takes to repair the indicator disc, the more caries resistant the enamel is. The investigated tooth in the left or right incisor, with repeated examinations, the corresponding tooth on the other side of the jaw. The disadvantage of this test is that the color reaction times depend on a number of conditions that are not always comparable: thickness of the discs, their tightness to the enamel, etc. A positive relationship between the solubility of enamel and predisposition to caries was found only at the organ and population levels. Organ levels at the level of an individual tooth and population levels in a large group of people. However, attempts to find the same relationship at the organismic level, that is, at the level of individuals, the research failed. At this slide you see the clinical case. The color of tooth when the first one you will start CRT test and the second one when you end the CRT test, and the ratio of CRT test. If you take from 70 to 120 seconds, this is a high enamel resistance. If you take from 40 to 70 seconds, average enamel resistance. And if you take from 20 to 40 seconds, is lower enamel resistance. So, what is a cariogenic situation in the oral cavity? Cariogenic situation is created when any cariogenic factors or group of them acting on the tooth makes it trophic to the acids. A cariogenic situation, in other words, is an imbalance between progressive caries and its absence. An imbalance is triggered by the presence of one or more factors contributing to dental caries. In regions with a high prevalence of caries, there are people who do not have this disease. This allows us to determine the group of caries-resistant peoples. The mechanism of caries is the progressive demineralization of hard tooth tissues under the influence of organic acids, the formation of which is associated with the activity of microorganisms. Initially, caries is an infection. Since the disease is caused by cariogenic bacteria, These are bacteria that absorb sugars and release organic acids. These include Streptococcus mutans. This is a group of microorganisms. Also, it was previously to be one microorganism, but now this is a group of microorganisms. The main etiopatogenic factor is plaque, because of it contains many of microorganisms. Risk factors of dental caries. These factors which produce cariogenic situation. So, all factors of caries occurrence are divided into two groups: general and local factors. The first one, general factors. Defective diet and drinking water without fluorine, with small container of fluorine, for example. Somatic diseases, shift in the functional state of organs and systems during the formation and maturation of tooth tissues. Extreme effect on the body. Heredity, which determines the usefulness of the structure and chemical composition of tooth tissue. Adverse genetic code. Immunodeficiency. Somatic diseases in the stage of decompensation. Chronic diseases. Pathology of the central nervous system. Endocrinic disorders. Blood diseases, etc. Hypovitaminosis. Specific infections. Stressful conditions. The second big group of factors of dental caries is local factors. There are tooth plaque, pathology of the composition and properties of saliva, poor individual oral hygiene, carbohydrate, sticky food, debris in the oral cavity, resistance of dental tissue, full structure and chemical composition of hard tissue of the tooth, deviation in the biochemical composition of hard tooth tissue and the pathological structure of tooth tissue, the condition of the tooth pulp, the condition of the dentition during the laying, development and teething, tartar, inappropriate therapeutic, orthodontic, orthopedic treatment. So, a bit more about local factors. As I said before, the main etiological factors is microorganisms. The mouth has a diverse resistance microbacterial flora. The normal inhabitants become established early in life. There have been a few epidemiological studies to investigate the link between oral flora and dental caries. Streptococcus mutans was first identified in 1924 by Clark and subsequently Lactobacillus acidophilus by Bunting in 1930. These acid-producing bacteria were found to be associated with the formation of dental caries. Streptococcus mutans is one in interest because it has the ability to formation extracellular polyformer of glucan, from sucrose, which aids the microorganism in adhering to the enamel surface and in establishing stable relationship there. Another extracellular polymer leaven is synthesized from fructose. It plays the role of extracellular microbial energy reserve. The other cariogenic microorganisms are Lactobacillus acidophilus and other acidogenic microorganisms in plaque and carious lesion may be capable of producing caries by themselves, or they may be able to act synergetically with Streptococcus mutans in caries initiation. Actinomycetes are gram-positive pleomorphic rods, which form a large proportion of the oral microflora of all mammals. Actinomycetes are also among the earliest colonizers of dental surfaces and may constitute up to 27% of the paneum bacteria. They have been emplaced in root caries, although their role in dental caries initiation and progression is not well understood. The next one local factor, the big factor, is dental plaque. Bacterial plaque is a dense, non-mineralized, highly organized mass of bacterial colonies in a gel-like intermicrobial, enclosed matrix or slime layer. It is a transparent film that can be supragingival, coronal to the gingival margin on the clinical crown on the tooth and subgingival apical to the margin of the gingiva. The dental plaques consist of microorganisms, and microorganisms are the etiological factor risk of caries. So, dental plaque is the local factor risk of caries, general local factor. The next one is the meal. It is currently known that the caries process can develop in the presence of microorganisms in the oral cavity. An excess amount of carbohydrates in food and the content of carbohydrates and microorganisms with the tooth enamel. It is well known that carbohydrate intake induces increased acidification. So, takes 10 grams of sugar leads to an increase in lactic acid in saliva from 10 to 16 times. Studies how show that at a pH more acidic than 6.2, saliva becomes undersaturated from a supersaturated hydroxyapatite. Therefore, it turns from a mineralizing liquid into a demineralizing liquid. According to modern concepts, the cause of caries is prolonged exposure to acid on dental tissue. The formation of organic acid is associated with long-term enzymatic activity of microorganisms. Long-term exposure to organic acids on tissue is observed with poor oral hygiene. When a dental plaque forms on the enamel, it is under it that an acidic environment is created as a product of the enzymatic activity of a huge number of microorganisms that are able to perfectly assimilate carbohydrates retained in the oral cavity. The next one is violation of the composition and properties of the oral fluid, which is an indicator of the state of the body. Salvia, the secret of the salivary glands, secreted into the oral cavity. Normally, an adult produced up to 2 liters of salvia per day. The rate of secretion of salvia is uneven. It is minimal during sleep, less than 0.05 milliliters per minute. In the oral cavity, the secreted by each of the glands is mixed. Mixed salvia differs from the secretion directly from the ducts of the glands by the presence of a constant microflora, which includes bacteria, fungi, spearheads, etc., and the products of their metabolism. Mixed salvia is a viscose due to the presence of glycoproteins. So this is a viscose liquid with a specific gravity of 1001 to 1017. Fluctuations in the pH of salvia depend on the hygienic state of the oral cavity, the nature of the food, the rate of secretion. At a low rate of secretion, the pH of salvia shifts to the acid side, while stimulating salivation to the alkaline side. The buffering capacity of salvia is the ability to neutralize acids and bases. It is the protective mechanism of the oral cavity. Salvia is the main factor in the regulation of the acid-base balance of the oral cavity. The buffering capacity of salvia is provided by 3 main buffering systems: bicarbonate, phosphate, and protein. Up to 80% of the buffering properties of salvia are provided by bicarbonates. The concentration of bicarbonates in salvia is directly proportional to the intensity of salivation. The next one is pH of salvia. In some conditions, the pH of salvia can mix in the acid up to 5.4 and alkaline up to 8 sites. This leads to a change in the colloidal crystalline structure of phosphorus-calcium compounds of salvia and the violation of its mineralizing ability. A change in the concentration of hydrogen ions in salvia significantly affects its saturation with hydroxyapatites. With a shift in pH to the acid side, its supersaturation with hydroxyapatites decreases, and at pH below 6, salvia becomes unsaturated with calcium hydroxyapatites and loses its mineralizing properties. Moreover, in this case, salvia begins to play the role of a demineralization factor. The next one is salivation speed. We talked about it earlier. A very important indicator of the state of salvia is ionic state, the value of which determines the activity of ions, including mineralized components. The ionic state is 1 is 0.03 on average. The next one is the surface tension of salvia. Determines the wetting ability of salvia to the tooth. A decrease in surface tension is observed in children after takes sweets. A long-term decrease in the surface tension of salvia is observed when a cariogenic situation occurs. One of the interesting properties of salvia is microcrystallization. Microcrystallization of salvia has features depending on the state of the body, the state of the oral cavity, etc. The nature of the microcrystals that are formed after drying. A drop of oral fluid on a slide reflects the mineralizing ability of salvia. How to determination of pH of oral fluid and plaque. Salvia is collected on an empty stomach in the morning in and around of 2 milliliters, and then salvia is examined 3 times using a pH meter and set the average pH. You see the scale and the numbers of pH from acid to carbonic. How to determine the salvia viscosity. Salvia is collected on an empty stomach as the last slide, and examine the viscosity with an oscillate viscometer 3 times. The viscosity norm is 4.16 units. Viscosity increase 2 times or more means enamel susceptibility to caries. And the other method of indication of salvia is the Stephan Curve. The Stephan Curve describes the change in dental plaque pH in response to a challenge. The type of challenge does not matter, but it is usually some element of the diet. On the other hand, the challenge could be an inert substance placed in the mouth with the aim of determining its effect on plaque pH. For example, mechanical stimulation of the salivary glands caused by mastication chewing gum base. This would be of interest in an investigation into the effect of salvia flow on the pH. While studying the changes happening in plaque after a challenge by a cariogenic food. Characteristically, the Stephan Curve reveals a rapid drop in plaque pH, followed by a slower rise until the resisting pH is attained. The time course varies between individuals and the nature of the challenge. The initial drop is usually rapid, with the lowest pH being attained within a very few minutes. However, pH recovery can take anything between 15 and 40 minutes, depending to a large extent on the acid neutralizing properties of the individual salvia. The initial rapid drop in pH is due to the speed with which plaque microbes are able to metabolize sucrose. Larger carbohydrates, such as starch, would diffuse into plaque more slowly and would need to be broken down before assimilation by the microbes. In the case of straight, salivary amylase would produce a mixture of glucose and maltose together with incompletely digested material comprising the branch point of the starch molecule, limit dextrins. The glucose and maltose would then be taken up by plaque bacterial and metabolized. The rate of straight breakdown slows up glycolysis and therefore acid production produce a less step drop in pH. The value of the Stephan curve is that it provided a means by which the cariogenic change to a tooth may be measured. Actually, it only measures the potential cariogenic challenge because the critical pH value varies between individuals. Okay, with Salivary we've done, so the next local factor is an appropriate therapeutic orthodontic orthopedic treatment. Orthodontic construction, orthopedic prostheses, irrational filling of teeth, overhanging edge of fillings, a poorly executed contact point, and other imperfections in the treatment lead to accumulation of dental plaque and therefore create a cariogenic situation. Most of the risk factors, one way or another, lead to an increase in dental plaque and, accordingly, microorganisms in the mouth. An index can be used to detect the cariogenic of dental plaque, I mean the plaque cariogenic index. It determines the acid activity of plaque colorimetric method for discoloration. Methyl red to yellow at pH 6.0 to red at pH from 4.5 to 6.0. Method: rinsing the mouth with 1% glucose solution for 2 minutes. Then, on the surface of the teeth with a pipette or swab, applied 0.1 solution of methylene red. Then we will interpret the dental plaque cariogenicity index with table. Table consists of 2 columns. First one is color and second one is cariogenicity of plaque, and 3 lines: yellow, pink and red. Yellow is non-cariogenic, pink non-cariogenic, and red high risk of caries. In addition, microbiological tests can be used also. The purpose of microbiological test is the ability to predict the risk of caries, set the activity of the caries process, estimate the rate of progression of the caries process, as an objective creation for evaluating the antimicrobiological effect of virus hygiene and prevention, monitoring the effectiveness of preventive measures. The kit of this test contains 10 reactive strips, 10 tubes for the substrate, 10 places, and 10 pieces of paraffin.